So Denise, do you see the slide?
Yeah, I do see your slides. I see them, all the slides, including your notes at the bottom. We can give folks a few minutes to log in.
Sure. No, absolutely. I just want to make sure it works. How about now?
Now I still see the regular PowerPoint page.
Right. Okay, good.
Not the individual slides. You know what I mean?
You don't see the individual slides? Oh, you see just the one slide.
No, I see all of your slides.
That's interesting. Number one. Let's see. Your screen share, stop share. How about now?
Yes, now I just see your slides.
Okay.
Is it okay if we start at like, I don't know, 35? I think it's just you today.
We got time.
Yeah. So we can start at 35. A few people are joining us now.
So there's that.
Hi, everyone. We're going to get started in another 2-3 minutes, so we can give folks time to log in. And then we'll go ahead and introduce the first ITE review session with Dr. Foster. And for those joining us, we will also be recording this session, and I'm going to try to post it on the NYPEM YouTube account at the end of this. Okay.
In the past, what's the best way for interactive besides just asking questions? Can you use the chat to be interactive, or what do you think is the best way?
It's up to you. It depends. I feel like in prior years, some of the faculty have had like a lot of content to cover in an hour's time. You have 2 hours today, but usually it's like a topic an hour. And sometimes it's like really, we go through all of cardiology in an hour, for example. So sometimes it's just the chats, just because the volume of content is such that it all needs to be covered. And then sometimes it's a little bit more interactive if there are like questions in between, but it's really up to you.
All right, so if I ask a question, I'll just ask for verbal. Doesn't like it's too many people today. That's good. I can see everybody. Just the 9 of us.
You can go ahead and get started. And just as a reminder, I believe welcome everybody. This is our first ITE review session. It's going to go till about 10:30. We are going to record it again. We're going to post it on the NYP website, NYP YouTube channel, I mean. And I believe today we have a guest either from NYP Brooklyn or NYP Queens. So welcome. And we are excited to be sharing the ITE review session with you today. Feel free to participate as you feel you can. This is a review session for us. And take it away, Dr. Foster.
Okay. So this was a set of slides that was first developed by this group of fine physicians. And I inherited sort of the outline of the talk, and then I've added a few things here and there just to sort of add a little bit of knowledge and understanding. So it's basically going to be very quick. We're going to show a question. You're going to let me know what you think the best answer is. You can either say it out loud. Someone can say it out loud if you think you know it. And no judgments here today. Everything that happens here today stays here. All right, so it starts with a pretty straightforward 40-year-old man presents with the following slit lamp exam. All the following are acceptable forms of treatment by the ED physician except. What do we think the answer is? Let's accept. If you want to type it into me on the chat if you don't feel like saying, or you just say it out loud.
Start off with what you think it might be.
Yeah, who wants to? I think I know the answer because I have them. But what do you guys think?
They have herpes in their eye.
Right. Now you want to be, so what do we call this? What are the other names for this? And it's important that, this seems very pathognomonic. It's got that sort of branching type of look to it, but it's called what? Do you remember? So it's a keratitis, a stromal keratitis. The one thing you do want to be a little careful of is that people who think they see stromal, that they think that this is definitely HSV keratitis, they're often wrong, even though it's a common. One of the things that's important to keep in mind for this is the fact that it is, just like any other herpes, it lives in the nerve, the optic nerve, and actually comes back repeatedly over someone's lifetime. And so just like any other herpes, it's very important to treat it for its antiviral. But what do you think is the one non-answer here? So we know we're going to treat with a topical antiviral. I'm sorry, or it could either topical or oral antiviral. Those are options. Is it ever wrong to give cycloplegics to an eye problem? It's like never wrong, right? Except for in closed angle glaucoma. What else? Which we don't think this is. So it's either topical antibiotics or topical steroids are not an answer. What do you think?
Someone give a guess.
Right, knocking it down to two possibilities is a great test-taking strategy. You always win if you do that. If you get it down to two answers, you will win in the end for any hard exam, large volume exam. But what do we think? Someone's got to say something. I can't move on without someone saying something.
Amy put in the chat an answer.
Steroids, topical steroids in particular. It's a good rule of thumb that you don't give topical steroids to the eye unless ophthalmology is specifically directing you to. Again, because we're wrong maybe half the time. And if it is something that would get worse with topical steroids, it is a bad thing, right? So in this case, you wouldn't use topical steroids. You might use systemic steroids. It's a little less of a issue with the eye to give systemic, but again, I tend to use steroids under the direction of ophthalmology. Very good. These are some other examples. I want to just show you other examples where you can get an eventual confluence of lesions on the eye. So this is also another example, but it can be very non-specific. This, for example, a little less of that stromal pattern, but still herpes keratitis. So the story of non-traumatic coming on, painful, and then especially if they have a history of this in the past, is very pathognomonic. All right, next eye problem. 85-year-old female presents to the ED with the following physical finding: no complaints, no trauma. Vitals do a little hypertensive, but otherwise afebrile. What is the most appropriate management for this patient? Any answer? We're here for 2 hours, but we got to say something.
Go home.
What'd you say?
Go home.
Go home. Artificial tears if they need comfort, if they even have any discomfort, and discharge home, right? So this is a
Subconjunctival hemorrhage.
very good. Quick, let's go to the next one. So the next eye one here, 30-year-old construction worker presents with eye pain and photophobia. The slit lamp shows the following. So in addition to removing the foreign body, what is the appropriate management?
Seems like giving antibiotics would be reasonable.
What is it? Giving what?
Antibiotics.
Right, so giving antibiotics is reasonable. Is it ever wrong to give cycloplegics?
No, if you're not concerned for like an acute angle. And then it's almost always wrong to give tetracaine to go home.
Yeah, except, and I will say that for purposes of most exams, I absolutely agree with you. I think we are changing slowly with our fear of topical tetracaine and sending patients home. I think ophthalmologists do it pretty routinely, and there's been some people who have looked from emergency medicine who have kind of said, I've done it, and there's no bad outcomes in whatever size of people we've done. But it is a pretty ingrained kind of no-no from my generation. So it's going to take a lot of evidence before people stop. But keep in mind that sending someone home with a few days of tetracaine and good discharge instructions, if they're reliable, could actually be very helpful. Yes. All right. And no one here.
So what about the rust ring?
Yeah, get rid of that.
Yeah, so we don't have to remove we have to remove the foreign body that's causing the rust ring. That needs to be removed, but not the rust ring itself by us. That's something that opto can make a decision. It can heal by itself without it, or they'll have to deal with it depending on the size. All right. So you don't remove the rust ring, thankfully.
If you are not in a place where you have opto available, then they have like a little eye spud thing that you can actually take the rust ring off.
Mm-hmm.
Or you can use a blunt needle if you're very careful.
Well, the blunt needle, again, is mainly for the initial foreign body. That's what removes so in addition to removing the foreign body, what do you do? And that, I think, can be done by opto. But removing the foreign body is something that we have done. I've done as a resident with a needle and a slit lamp. It is a terrifying prospect until you do it and you realize how easy it is. All right, next. 23-year-old female prevents to the ED complaining of pain after getting hit with a volleyball. All of the following statements are correct, except. Which one's the except?
I feel like she doesn't necessarily need surgery.
So you say which number? Number 3?
Yes.
Okay. Okay.
I don't know.
And that's the except, right? So most of these patients do not require surgery within 24 hours. Your biggest concern is an outlet obstruction and glaucoma. So careful follow-up by opto is definitely required. But and what is this called? Just want to make sure we are understanding.
Hyphema.
Right. So that's something to look up and make sure you have a good sense of it. But Hyphema. What if this was an infection and it was white cells? What would that be called?
Matt,
Hypopion.
Hypopion. We can pronounce it.
Whatever. Yeah.
All right, and that's the white cells. Sometimes you just see cells in flare with infection in the cornea, but this is when they're actually enough to layer. This is what it'll look like. All right. All of the following are causes of the findings below, except, and so it helps to sort of just ask yourself, what are the things that that you're seeing? So cluster migraine headache, carotid dissection, tumor, trauma, application of pilocarpine to the right eye. Which one do you think seems the except? What are we seeing? So you can either describe what you see or you can describe the answer, or both.
Ptosis and mydriasis.
No.
Oh, no, oh, ptosis and meiosis
Right.
There you go. And
on the
oh, and
others,
if you-
on the
and-
patient's left.
Correct. Right. So what
touch
does
the,
this? What does pilocarpine do to an eye pupil?
It dilates the pupil.
Nope.
Am I, okay, whatever, someone else has to start talking.
It's okay. This is good. Safe space. This is a very safe space. So pilocarpine is causes what?
causes meiosis.
Right. It causes it'll close. It'll make the eye a little smaller. And it can go on.
So is this 5 like Heidi said? Because I mean, we're looking at the guy's left eye, and the 5 has it to the right, applied to the right eye.
Right, exactly. So for two reasons, two easy reasons, it's not pilocarpine. One, it's a dilated eye on the right, and two, there's ptosis, and pilocarpine has nothing to do with ptosis. All right, so it's going to be one of the other things that press on your cranial nerve 3 that's going to cause you these other things. Okay. Any questions? No. Okay.
No, but they know what's going on, right? Like they know what the diagnosis is, right?
Who's they?
The residents.
Oh, yeah, no. Oh,
The other part of the triad is anhidrosis.
right.
Very good.
Very good. Very good. And what we call that?
Somebody else say something.
When you have the meiosis, ptosis, and hydrosis, and
There it
sometimes
is.
Heidi-
Good job, Heidi. You got it, Heidi.
Yeah,
there you go.
Heidi says Horn syndrome.
All right. Next is 14-year-old boy playing football was struck by another player, fell to the ground, hit his head. He was brought into the emergency department for evaluation. Brief period of loss of alertness. EMS reports he has been awakened and alert throughout transport. He complains of headache and some neck pain. What is the next best step to be taken?
Get a CT. It's like maybe CSF.
Okay, so CT scan is definitely in his plan of action. Is there anything else that's in the plan of action?
I agree with Amy. Amy says 4.
Fly cervical collar, right? Okay. In the end, that is actually what they were looking for. I think, if you look at the neurosurgery literature and if you look at older EM literature, it's a no-brainer that everybody is so focused on starting the cervical collar. We do know that from EMS literature, which is slowly making its way, we see it practically in our day-to-day EM experience. When Osmond and I were practicing emergency medicine as residents, everybody came in with a cervical collar. Everybody who got any kind of little ditzel on the head was brought in on a cervical collar.
Oh, don't forget the board.
And the board, cervical collar and the board, right? So I think people are more real that the literature definitely is de-emphasizing the long board, unless there are multiple spinal injuries at multiple levels. But for cervical in particular injury, collars are still mentioned a lot in literature, but we're realizing they probably do a lot less in the awake and alert patient. Things that, of course, that no one's going to fight you on is if there's any neurologic symptoms. But the real thing to keep in mind is that why are people ordering the CT scan? Because they're worried about that this is an example of?
Epidural,
What'd you say?
epidural bleed.
Right. So it's CSF leak, right? That you're seeing this rim of clear around the blood that's coming from the nose, let's say. So this is a definitely indication of possible basal skull fracture. And basal skull fractures are associated with cervical spine fractures. There is something that something that you should be thinking of. So putting on a collar is definitely, seeing this makes it higher than your typical patient with neck pain. So cervical collar. The next step is actually, before you order the CT scan, you are obligated to consent with the, get consent, unless you feel someone is deteriorating and life and limb is threatened there and then. You do have an obligation to at least contact the parents for their consent for things like a CAT scan.
So Jordan, just that's a drop of leaking fluid from somewhere on the head,
It's
Usually-
blood with the CSF double ring.
usually from
right?
the nose, right? Usually.
Yeah,
Right.
so it's either otorrhea or rhinorrhea, right? So
Mhm.
hopefully you would see a raccoon's eyes or a battle sign.
Right, you could see those as well. All right.
And you let it.
Or what's the other
let
thing?
the-
And what's the other one? Raccoon eyes, battle sign, and the other thing you can sometimes see? What's the other thing we sometimes say is associated with basal skull fracture in head trauma?
Hemotympanum.
Hemotympanum, exactly.
You can also send this fluid for beta 2 transferrin
You could, if you were.
if you had a lab that run
I
it.
do not know how long that would take in our particular institution. I think we would get a CAT, one of the few things we get a CAT scan before we got that.
Well, we work at an Ivy League hospital, so I'm sure it would come back.
Right, and amazing things happen here. Okay, 43-year-old female, 18 weeks pregnant, involved in an altercation 2 days ago, comes to the emergency department for evaluation, complaining of headache. The patient reports unilateral decrease in hearing, and the next, you see this when you look at the otoscope. What is the next appropriate step would be? What do we think this is?
I think 3. This is hemotympanum.
Right.
I've never
exactly.
seen it though.
Exactly. So this is hemotympanum. And when you see hemotympanum, there's a couple of reasons. Sometimes just the pressure of direct trauma to the ear can cause a rupture of vessels, and you can get bleeding behind the jump. But also it can be a basal skull fracture. It can cause hemotympanum, especially a couple days old. It can look dark like this potentially. So you're getting the head CT to see if there's anything other injury, including a basal skull fracture, like we did the other case. ENT was someone who, while they could be called, probably the next thing you would care is any question about what's going on with the baby, if there's trauma with this kind of head trauma. This could be something that could affect the baby. If there's other trauma, because that's one thing. This is clearly a patient who is not being forthright with all the things that could have happened. And you want to just be very careful and very trauma-based informed care, trying to be very patient, trying to get history. But there definitely could be injuries not reported. And then finally, how many of you would call crime victim services? This is a poor woman who's been battered to the point where she could be and has this injury.
I guess, yeah, I'm not sure because if it's just a woman who's being battered, it's up to her if she wants it to be reported. But if she's pregnant, I'm not sure what the rules are.
Right. So still, there's no duty to report in New York State for anything other than child abuse, even elder abuse, even abuse to someone. It's very important that you get the patient to understand what the options are, and that you definitely will help them. But it really has to be their decision to get anyone else involved, whether it's crime victim services or even notifying the police. Those are very much up to the patient, and she's clearly an adult. It becomes a little different when they're less than 18, but that's for the normal adult. Any questions? All right. All right, this 24-year-old male prisoner presents the emergency department for evaluation of neck pain after a fight in prison 2 days ago. Patient complains of numbness in his arm and to his fingers, but no weakness. The next appropriate step to be taken is a little bit of a theme.
2.
Right. So we talked about cervical spine mobilization in the setting of what is this?
Battle sign.
And that means that we're worried about,
Basilar skull fracture.
which is associated with cervical spine. And in this case, it'd be very hard to argue, considering that he has numbness in his arms and fingers, but realize anyone who's tried to study this has not found any real benefit in the alert patient. Patients who are alert and awake are protecting their cervical spine on their own. So if you put it on and they feel more comfortable and they feel good, but if they're once you put it on, they're screaming, they're trying to take it off, probably doing a lot worse if they're writhing around because of discomfort from a collar. Maybe taking it off may actually be the better of the two choices. But you should be looking to put cervical spine immobilization. And if it makes them better, perfect. All right. All right. Now, 27-year-old male is admitted to the ICU after an MVA, intubated and immobilized. Upon examination, an astute intern notes the following finding. What is the next action? So either the answer or the answer here, or what we think is going on. What do you think?
Septal hematoma.
You said what kind of trauma?
Septal hematoma.
Septal hematoma, right. It's something that we rarely see. How many of you have actually seen an actual septal hematoma? Anyone here? You've seen one. Interesting. Yeah, so it's very rare, but you have to look for it. So what is the treatment then?
Poke it with a knife.
Right, incision and drainage. We want to get that mucosa back onto the cartilage so the underlying cartilage will get the blood supply that it needs and does not necrose. Got it? All right. Very good. All right. This patient comes to the emergency department 2 months after a broken nose, and you remember being the treating physician at that time.
Oh, no.
He is concerned of his appearance, and the next appropriate management should be
A call to 911 so they can arrest the criminal.
call the 911. All of the above. No,
'Cause we're trying to keep our community safe.
that's right, and that's why you calling the police. Trust me, always ends up you're causing more problems if you have.
Wow, Neil. Wow, that was a really good answer, Neil. Great job.
What else you got? What's the answer for this one?
I would say
Yeah.
one.
I'd probably say one.
Yeah.
Wait,
You
Neil,
check
please don't
those,
talk over
make
me.
sure there's no septal hematoma.
Yeah,
but-
we have to agree, Neil.
Yeah, so call our attorney. So in the end, you don't have to call any attorney. Everything was done appropriately. A fractured nose is not something that we need to or can intervene with within acutely. Swelling has to go down. You have to see what the deformity is, and unfortunately, it's going to be either ENT or plastics as a plastic procedure, which is they're going to have to really struggle to get this paid by insurance. But that's the follow-up, and that's the only care we can give. Anyone done anything any different? All right. Next is answer one. All right, maybe a little more serious. 25-year-old male presents with the following penetrating injury.
Ooh.
His vitals are stable and airway is secured. All of the following statements regarding this injury are correct, except
Probably two.
Agree with other Neil too.
Thank you, Neil.
right. So the except, right. So we do think it's associated with high mortality. We do think that it's the structures that are at risk include the great vessels, the trachea, the esophagus, and the spinal cord. And we do agree that the kinds of tests that would be necessary to figure what any of those are injured include laryngoscopy, endoscopy, and angiography. Okay. So we don't think that this is likely to be right. We know there's going to be potentially hidden injury. So just to quickly review, the zone 1 is what we're talking about. You've got clavicle to the cric, zone 2 from the inferior part of the cricoid membrane to the angle of the mandible, and then from the angle of the mandible to the base of the neck. So here's it from the side, so we can get a better sense from the side what it looks like. Here's a side view showing all those structures we talked about. In this zone 1, we see the lung, we see the great vessels, esophagus, we see the trachea, we see all the great vessels, so on. And then you start to continue to have, you don't have the lung in zone 2, but you still have large vessels, esophagus, and then up here, some vessels as well in zone 3, near the parotid. And so zone 1, we talked about, right? Zone 2, the picture kind of reminds us what's in there. Starts to get into the larynx and the spinal cord, also continues to be an issue. And while zone 3 is the carotid and vertebral arteries, you also have just the higher pharynx and higher part of the spinal cord. So zone 2 also needs routinely vascular and esophageal evaluation, even though that first picture was a zone 1, which also needs all these things. Now, any patient with platysma muscle violation must be admitted to surgical service, and do not explore wounds in the ED that violate the platysma. Any questions? No, no one's pulling out any knives in the ED. All right. Any questions? All right, moving on from the head and neck. This is a topic that's near and dear to me. The 23-year-old male presents with intermittent episodes of tachycardia and syncope. Which of the following medications is indicated? What do we think is going on here? Assuming it's a tachycardia. Do we see, where do we see the abnormality? Is it STT waves? Is it the QRS? Is it?
It's all over. So
Well,
what I
hold
see
on.
is,
Wait, before you answer,
Okay.
can I just, for the junior residents, if you don't know what the EKG is, just from a test taking strategy, take a look at the answer choices and see if the answer choice is right, they would inform what the tachydysrhythmia would be. All right, so now that you've had that moment to think about it, all right, Matt, go ahead.
so I think V4, 5, and 6 show it best, probably. So you've got your P wave, very short PR. You get the slow upstroke of the QRS, which is the delta wave, and a wide QRS. So he's got all the classic signs of WPW. So in real life, it really depends on what the patient looks like.
So stable or unstable? If they're stable, what are your options?
If they're stable, you can do pretty much whatever you want. And if they're not irregular or an AFib, but the test answer will probably be procainamide.
Right.
Because it blocks the accessory tract.
Mm-hmm. Okay. And you said not AFib. What is the problem if somebody has AFib and WPW and has a tachycardia? What then becomes the thing you have to consider?
Yeah, because they're just in like normal AFib usually, but then if you give them a classic rate controlling AV nodal blockade agent, then you're gonna turn off their EV node, and their atrial fibrillation is gonna go down the accessory tract and be converted into ventricular fibrillation, and they're usually unresponsive to defibrillation because even after you shock them out of it, they still have their accessory tract blocked, and it's just going to happen again. So these people you can kill people if you do the wrong thing.
Right. So AFib, classically, AFib with WPW is presenting as alternating wide and narrow complex. When it's going down either the AV node or the accessory pathway, they're kind of alternating, they're competing with each other. When it goes down the accessory pathway, it's wide. When it goes down the AV node, it's narrow. So a classic irregular alternating wide and narrow complex rhythm is pathognomonic, and there's really not a lot of that tells you this is AFib with a very large accessory pathway. And you're absolutely right. Every time the signal from goes down the AV node, there's an inherent refractory period that prevents the ventricle from beating too quickly. But as soon as you have rates down the accessory pathway, only there's no refractory period, and the ventricles are going to try to go as fast as the signals they're receiving from the atrium, and that will be 300, which instantly turns a ventricular into ventricular fibrillation. So you try to avoid them in that. But if you have a normal orthodromic or retrodromic, if you're a retrograde, even with WPW going down, and if it's always the same, any AV nodal blocker will actually break the cycle, and you should go out of the you should go out. But it's only but then in AFib, that's the one different time. So any wide complex with a short PR interval, we tend to be a little careful because this alternating between wide and narrow complex, sometimes you don't see the narrow complex for a long stretches, and vice versa. So it can sometimes be hard. So, a lot of people, when they see a wide complex, short PR interval, they say, as long as they're stable, they tend to do an antiarrhythmic. And of the two, it's interesting, they say procainamide. There was a lot of money given by amiodarone maker for a long time, and it was used to be considered to be the choice drug. But when you compare them head to head, procainamide is the better medication anytime they've been compared. So it's good to not just fall for the hype, as they say. So procainamide, it's cheap and it's the best medicine for this. Any questions? All right. Next is, all right, so that's 4, procainamide. Next, 47-year-old male presents with 2-month history of recurrent episodes of vomiting. He recently completed a 7-day course of antibiotics for pneumonia. He presents with persistent cough and is febrile to 101. Chest X-ray is taken. What is most likely cause of this condition? What do you think you see there?
So he's got.
Excuse me, Neil.
Thank you.
I
Wait.
think I
Neil,
can take
Neil,
this one.
no, please.
All right, Neil, I think there's an air fluid level in there.
Looks like a lung abscess.
Lung abscess, Neil.
So what do you think is causing that? Most likely.
I would lean towards probably strep pneumo, but I'm not sure. I don't think chlamydia or peptostreptococcus or cryptococcus. I don't think he's immunodeficient, or they're not giving us that story. So I don't know. I'm leaning towards strep pneumo.
What do other people think?
I feel like chlamydia, you get more of the diffuse picture.
Right.
Cryptococcus.
Or maybe Staph aureus.
Yeah.
Staph
Maybe,
can make those abscesses.
maybe Staph aureus. I think what they're trying to get though is that this is an aspiration pneumonia. So I feel like they probably want oral flora. So because it says most likely, I would probably say staph. I feel like peptostrepto is one of those that the people with really messed up lungs get, like CF or bronchiectasis. So my final answer is Staph aureus. And my name is Neil Babsar.
And as the other Neil Bausar, I concur.
I will say this, that it is probably staph and peptostreptococcus are the two answers that are most likely to be the cause of this. But for this particular case, for some reason, they're saying peptostreptococcus as the more likely. But in the end, both staph aureus is definitely, hopefully they won't be giving you something which has two very likely answers. But the peptostreptococcus from the vomiting and the anaerobic nature concerns is where that comes from. Any questions?
Jordan, I think if they had said maybe like a post-viral syndrome, and then now you've got the cavitary lesion, then maybe the Staph aureus might be a better answer. But in this case, like Matt's saying, that you're dealing with a right middle lobe region or right-sided kind of in that area, you know, a lung abscess there. So in that case, then they're trying to lead you to an anaerobe. So my guess is that's why they're saying Streptococcus there.
And then alcohol use disorder in general, staph, Klebsiella, and strep pyogenes are all very possible. But in this case, right, oral stomach or oral organism anaerobe is the story that they're trying to picture. All right. So which of the following is not a cause of this patient's condition on chest X-ray? I hope you can see it clearly, at least. Looks a little out of focus, not terribly. What do people think is going on in terms of the lungs? And
it looks fluffy.
Looks fluffy. Okay, so it looks fluffy. So, agree with that. You still see good diaphragm borders. What else do you see?
A normal cardiac silhouette.
Right, and a normal cardiac. So what do you think that is? So you're looking at the choices here. What do you think?
So I think probably not A, B, or D. Most likely C, because you can get pulmonary edema in some situations.
Remember, this is the key. This is what's hard. What's not a cause of this patient's condition? Which one do you think it's not?
I said C, but now that you're telling me that, I don't know. I don't think opioid toxicity can cause. I mean,
all right. What do people think is the not here?
Hint: the heart size is what?
Oh, so you're saying CHF because the heart size is normal,
right?
Okay.
Yeah, that's really what it boils down to. Normal heart size with acute pulmonary edema. Do you know what HAPE is? What is HAPE? I just want to make sure you guys know HAPE.
High altitude.
Right, high altitude. So things that don't affect heart size: high altitude pulmonary edema, opioid toxicity, and naloxone administration. Now, there's debate as to when people do see a post-opioid patient come to an emergency department in a pulmonary edema, non-cardiogenic pulmonary edema, what was the cause? It actually is more of a sort of unknown than I think some people. I know a lot of people in the ED are sort of leaning toward the naloxone and the deep inspiration and the negative pressure. But even without that, people have seen this. And so just taking opioids puts you at risk for this as you come out of it. It might be, I think the negative pressure might even still be there as you're sort of losing your respiration. You can have definite increases in intrathoracic pressure without necessarily needing the naloxone. The question is whether naloxone also adds some other issues. But in the end, there's some debate, and so you always have to put opioid toxicity and naloxone administration together. It'd be impossible to tease those two out as the cause of this. Even if they'd said this person was using opioids, you didn't know which one it is. They're both contributing, potentially. Any other questions? So not CHF because of the small heart.
I guess I just don't normally associate opioid toxicity with pulmonary edema. I don't know if I'm wrong to think that way.
That's what I'm saying. So a lot of times people more seem to be sort of thinking of it as the naloxone that's causing it, but you have to appreciate that in the literature, it's actually not that clear. And people with just opioid toxicity can get this. Usually it's because they've become apneic for a while, but even without naloxone, they can develop this. Right. All right. And people do talk about, giving positive pressure. People talk about giving positive pressure before giving naloxone. It's not something we tend to do because we tend to give naloxone to people who are pretty, but giving some oxygen support can sometimes maybe decrease it, but it hasn't been shown. That hasn't been sort of borne out. Anything else? All right. 55-year-old alcoholic presents to the ED with acute onset of abdominal pain and vomiting. And he is febrile to 39.5. Blood pressure is 90 over 70. Pulse of 130. Stats 95%. X-ray is below. Which of the following is the most definitive treatment for this patient?
Surgery.
Surgery, right? Which one is surgery then?
Laparotomy.
Correct. And if anyone here has ever done a DPL besides Oz and I, that would be very.
And Manish.
Finish.
Manish, you've done DPLs? Wow, it's been a while.
Yeah, a bunch.
So answer is for
Does that mean if they're not
what do you think it is? Mhm. What's the question?
Manish does them even if they're not indicated.
There you go. Just to get the experience. Well, what do we think is going on this wonderful upright chest X-ray? What do we think is going on? What do we see?
Air under the diaphragm.
Right, clear air under the diaphragm. Now, sometimes it is every once in a while you're going to get a sort of an ability for a little bit of the intestine to sort of sneak its way behind the liver, and it'll look like free air. But in this scenario, with the fever, the whole low blood pressure, the tachycardia, this looks pathognomonic, and you have to get surgery right away involved. All right. Okay. The condition demonstrated in the following abdominal film is best managed by. So what do we?
So it looks like there's a bunch of little things that are all the same shape throughout the bowel.
Right.
So that makes me think that it's not natural. And and the lines are all too straight. So what I feel like we're looking at is a drug mule from okay, whatever, fine. Next question, I'll let them. So I would say A, because if the patient's not dying in front of you and they're just going to poop them out anyways, which is what their intended mission was, then I would just let them complete their mission.
Anybody else?
Is that a coffee bean sign? I don't know.
No coffee bean sign.
Yeah, the danger is that those things rupture.
Right.
So just
right now, we're not getting any vital signs, but assuming the vital signs are stable, they can become unstable pretty quickly. Right. So what do you think? If the concern is that this patient could become unstable very quickly, what do you think the next step is?
Let your surgery friends know.
Right, but what do you think is best managed by at this stage, assuming stable vital signs? I agree. I do think getting surgical consultation is.
So D, are you saying D?
What?
Are you saying D? Lysis of the adhesions, or?
No.
You want to expel the contents as fast as possible. How do you do that?
Flush it out.
There you go.
Right. So whole body irrigation is pretty accepted to be the treatment of choice. You start with that, you get it out as quickly as possible, hopefully within a few hours, but it can take a little longer. The only contraindication for giving whole bowel irrigation is if you had signs and symptoms that made you very suspicious for true obstruction. They were distended with pain, they had other things on the x-ray that looked like it, or you got a CT for whatever reason that showed obstruction. That would stop you from doing whole bowel irrigation. Obviously, abnormal vital signs. Getting surgery involved is important, but they're going to watch and see whether the packs can come out with whole bowel irrigation. If it does, they're done. But if not, they should be aware and ready to take the patient to the OR. If any, depending, of course, on what substance it was in those packets, will depend on what symptoms you're looking for a rupture. And then ruptures, of course, cause all sorts of things, including bowel ischemia and perforation, depending on what it is.
Like, can you highlight where you see the packets? I guess I'm not really seeing it, or maybe my quality here is not that
Okay,
great.
all right, Neil. Neil, listen up. So you see
You
all
can have
these
a-
different things that look exactly the same, right? Like you seeing, it looks like
It looks
they
like
look
coin roll, like
they
quarter
look
roll.
like mini like soda cans, right?
Oh, okay, now I'm seeing it.
And they all look exactly the same. So
Okay.
unless your patient is a robot and they're packaging their poop into nice little soda cans, it's not going to look like that, right? Nothing
Okay,
natural, nothing natural looks like that.
I think my chat
So-
was covering that part of the picture.
So either the patient
So I just have dilated lobes.
is sitting on a bunch of little soda cans, and they're probably going to be very uncomfortable because that doesn't sound comfortable. Right?
Well, even for the metal would, so batteries.
I know. But
That would be a lot more dense, right? We would see a lot higher density.
Yeah.
That's the thing, what are these things? They're pretty translucent. You can see bowel through
Yeah.
them. So it's something that has some translucency to the X-ray. So it's not metal. That's what we have.
I'm
And
just
trust me,
explaining for Neil,
Thanks, Neil.
You really good of you,
All right. So that's good. Okay. And if they do develop obstruction, then surgery is going to need to do lysis, potentially anything in terms of the laparotomy. All right. Next. All right. Moving away from the belly. So after flexing the shoulder and applying traction to the arm, which of the following techniques should be used to perform scapular rotation? So what is this trying to demonstrate? What's the technique? You know the name?
scapular manipulation.
Right.
Right.
Mhm.
Is there a different name?
Sometimes when combined with others, they say, well, yeah, that's the main thing. Scapular rotation, yeah.
So you basically have to push, like this person, if it's the patient's right shoulder, like in the picture, you'd want to rotate the whole scapula clockwise.
So that's pushing what letter to what letter?
Yeah, let me read this
C,
things.
C to B.
So I would say 2 is correct.
Right. C to B.
Because you want the whole thing to spin clockwise. So
Right.
that the glenoid where E is flips down and meets the humeral head.
Right. And of all the things, the most important thing, if you look at just video after video of, relatively comfortable patients who are getting their shoulders reduced, whatever technique you do use, the key is that the patient has to be in the right position and relaxed. They have to be able to sort of respond to vermal stimuli, have their shoulders be as relaxed as possible. There's some techniques that spend time just relaxing the muscles with like various massage type points before doing it, but it's the relaxation of those muscles that's going to probably predict your success more than anything else. So nothing sudden, nothing jerking, very slow movements. And then there's a whole series of possible techniques that will work for this. But scapular manipulation can be combined with a lot of other ones as well. And it just sort of helps for anterior dislocated shoulders, getting them back in position. Okay, that's really it for this one. All right, more on the extremities. This is just sort of looking at a normal elbow. I don't want people to get too crazy. But a normal elbow with an anterior fat pad, which sometimes you can still see, no posterior fat pad, an alignment into the olecranon. This is a pediatric case, olecranon potentially. All right, so then we go here. What do we think this x-ray? 9-year-old boy fell off the monkey bars onto his hands, present with the following injury. What is the most appropriate treatment? Closed reduction, hospitalization, hemarthrosis aspiration with a local anesthetic, followed by a sugar tongue for a week, long arm cast for 6 weeks, posterior splint for 2 weeks, and then progressive mobilization, or sling and swath immobilization for comfort with early mobilization as soon as possible. So what do we think was going on with the X-ray?
Can someone describe the finding, the positive finding?
Okay, so basically what I'm seeing, to me, what's most obvious is in the right smack in the middle of the picture, there's a cortical disruption in the thing that looks like a circle. So that's concerning for a fracture, Jesus, Neil, fracture, right around the, like the distal humerus. But you, you can also see the elevation of the posterior fat pad. Sorry. So yeah, so I just want like some of the like the juniors, because I like didn't understand what posterior fat pad meant for a while. Sorry. But basically it's, see how it's like it's more translucent right to the just immediately to the left of the bone. So basically what that's showing is blood has gotten into the space between the like the bone in the olecranon fossa and the fat pad that sits in that olecranon fossa. So it is pushing the hypodense fat out of the olecranon fossa, and it's making it more translucent. And that's what that darker space the darker space to the immediately to the left of the bone is. So that's what a posterior fat pad means. And someone correct me if I'm wrong, but this makes me concerned because this looks like it's a articular surface. So I would say closed reduction and hospitalization, because I feel like this patient will need surgery, but I don't know for sure.
Okay. What are the things that we worry about? So what kind of fracture did you say? I apologize. We know there's a fracture, and what would you call the name of that fracture?
Well, to me, it looks like a it's like the distal humerus, like the, I can't remember what the name of it is. Like, is it like the trochlea?
Well, you're right there. Do you know, in Matt or other Neil, do you know exactly, like in adults, right? When you see these fat pads, it's a problem with one bone most commonly. In kids, it's usually a problem with the other bone that you're saying here.
Oh, maybe
No?
Adam Morris is giving us the answer. So he says supracondylar.
Yeah, so in kids, it's usually supracondylar, and in adults, it's usually radial head.
Yeah. Well, as you said, as they say, radiology says one view is no views. But yeah, so that's very concerning, the supracondylar. So that patient will need surgery. Because there's lots of important things around there, like nerves.
Right, exactly. There's a lot of nerves, and especially, I mean, there's gratings. Basically, if it's completely non-displaced, like you see the fat pad, you've got tenderness, but you're just seeing the barest of lines, or maybe not. That is something like a type 1. You know, there's options for outpatient follow-up. But as soon as you start getting, and here we kind of see it going all the way through from one end to the other with a separation, not angulated, but definitely separated the whole way through. The idea that this is a type 2 supracondylar fracture is something that if you're hearing that from ortho and radiology and from your read, that's something that is very highly associated with nerve injury and at least a day of observation to expedite the possible intervention and watching for nerve damage.
Jordan, when you say type 2, are you doing the Salter classification? Is it?
No, this is for particularly supracondylar fractures. They have a grading system 1, 2, and 3. 1, if it's no disruption. 2, if you've got a disruption that goes through one end. 3, actually, should say 3 is both ends. I'm sorry. 4 is if it's like completely separated and like not even touching. All right. Next, so that's one. All right. So be careful of that. These are some other, this is just pictures of alignment. Let's see, and this is a dislocation. Yeah, this is something where you're seeing the posterior fat pad here. So you don't really see much. The fracture is actually in the radial head. This is an adult. This is a radial head fracture that's presenting with the posterior fat pad sign, as well as the anterior a little bit. All right. And this is a dislocation of an elbow, clearly not aligned. All right. These are just some extra things. And then this, again, we see a posterior fat pad with this fracture here through the, you got it, olecranon. All right, so the fat pad, that posterior fat pad, people are a little more, hopefully a little more comfortable seeing that, including here. And of course, we've had it here. Okay.
We actually, Neil, the residents and I put back an elbow dislocation last week.
And nerve damage is definitely something you worry about, but it's definitely right. But it's if you don't, yeah, that's why you just make sure you're very careful with your documentation and exam. All right, next. All right. So here, what is the most common injured nerve in the following X-ray, and name the injury on the X-ray? All right. These are your two views. So for those that want two views, this is it.
Is that a perilunate dislocation?
Why do you think it's that?
Kind of vibes, honestly, but also partly because I think there's like some like volar or dorsal displacement, and I think in this I'm not seeing like a volar displacement. I think with the lunate dislocation you get like a volar displacement or something like that.
All right, let's unpack that. If so, this is the lunate is this moon-shaped bone right here, right? And that's what the capitate sits in normally in a normal X-ray. And so if it's a lunate only dislocation, then that capitate is going to still be in line with the bones of the lateral aspect of the ulnar and radius. You're going to still see the capitate kind of still aligned right in the center, right here. But this, we're seeing that capitate now all the way posterior, not at all in line with your radius ulnar midline. And when it's that far dorsal, then that's what is dislocated, not so much the lunate, right? So then it's not the lunate that's so much dislocated, it's a perilunate, because it's the disruption is really up here posteriorly with the capitate and the other bones of the hand. Does that make sense? If it was lunate, this would be more anterior, it'd be more toward the anterior, the volar. Does that make sense?
Actually, yeah. And what helps me sometimes, Jordan, with this is that when I see this, you still see the radius, right, like aligned with the lunate, and
right.
Often the capitate and metacarpal structures are displaced dorsally.
Exactly.
But in a perilunate, like this is, in the lunate, then you see that the line of the radius is still in with the metacarpals, and it's just that the lunate is popped out. And
right.
So for the residents who are in the chat, it's the lunate dislocation. That's the spilled teacup, or on the AP, whatever it's with AP. It's the piece of pie, but this is the perilunate.
All right. So what nerve do we expect to be a problem injured with this? Do we know?
I can't remember, but I'm gonna make an educated guess and say 2, median nerve, because it
Mhm.
goes directly down the middle of the palmar aspect of the wrist and hand, and
Exactly. Mhm.
and you're making if you can, yeah.
Yeah, excellent.
Yep, absolutely. So perilonate dislocation, most associated with a median nerve, and often these are associated with scaphoid fractures more than half of the time. And so that's something you also have to consider in terms of other imaging just to make sure. So here's some pictures. When you talk about wrist fractures, while the scaphoid is the most common fracture of the carpal bones, remember 15% of the time you're not going to see it on initial X-ray. That same 15%, by the way, not seen on initial X-ray, also applies to your hip fractures, your femoral neck fractures. Up to 14% or close to 15% of those also will not be seen on initial X-ray, all comers. And so these are the types of bones that need other either interventions. In this case, it's a thumb spica, even if the X-ray is negative, as long as there's tenderness in the appropriate area. And then in terms of looking at the AP view, they talk about the lunate dislocations also just by this change in the orientation of the lunate bone, even though it's going anterior the way it is, you are going to get a space and a tear between the scaphoid and the lunate, which is often why the scaphoid is fractured as well when the lunate becomes dislocated. But here we see the normal relationship, lunate, scaphoid, right on line with the lunate is the capitate. And the question is here, we see that the capitate is still in the second picture for lunate dislocation. The capitate is still kind of right above in line with the sort of radius and ulnar, you see. And so the lunate dislocation pops forward. The lunate is dislocated. However, when the lunate stays where it should be, but instead the capitate and all the other bones are kind of popped backwards, that's your perilonate dislocation. And the way you just figure this out is by drawing a line through that capitate to see how centered it is, or just seeing how the lunate is centered. But both should be consistent. Now, even though we call this anterior, this AP view, this new space between the scaphoid and the lunate, no one really has to make the diagnosis on just an AP, but they have a lot of Manish, you said something about another sign. You said a pi sign. Is that what you were talking about? The Terry Thomas sign? Is that another name for it?
No, because that's the Terry Thomas, or now the Michael Strahan, is the scapholunate
Yeah, I said
dislocation.
David Letterman was the other one.
David Letterman was the other one. Yeah.
But Strahan is much more pronounced. It's true.
Yeah, but the piece of pi is actually also the lunate dislocation on the AP. So it's either spilled teacup or piece of pie for lunate.
Okay. All right. So keeping with the hand, arm, 20-year-old male was in the desert minding his own business. Always the case. When he got bitten by a snake, patient presents 6 hours after the incident. Vital signs are stable and all labs are normal. What is the appropriate treatment?
Okay, well, immediate impressions are that this hand is really swollen, and as you can see by the person who's making marker lines on this patient, that it's rapidly progressing if it only happened 6 hours after.
Right.
So I'm concerned about either some weird heme thing going on from the snake venom. Dude, I am so tired. Sorry, I keep mispronouncing words. But the snake venom causing some like DIC or thrombo, like coagulopathy type of picture, or a rapidly progressive infection. Yes, exactly. So I think because the labs are normal and the vitals are stable, that it's probably more consistent with an infection. So what I would probably do is is uh IV antibiotics and admission to the hospital. I feel like
Wait, Matt, think, no.
oh, and
think-
the sorry, and the antivenom.
Got it. So that means
Number four. Number four.
Right. And that's something we don't think of a lot in this hospital because we don't have the antivenom, but it can be brought to this hospital, or we can transfer patients to a center that has it. We have maybe some antivenom. I don't know whether we have even the most common ones, but obviously we go to, what's our snake bite center in New York? Do you know who you'd call?
Poison control. I don't know.
Who's
Poison control will tell you where to go.
who's
Yeah,
close to the Bronx
Bronx
Zoo?
Zoo. Yeah.
Oh yeah.
What'd you say, Oz?
I don't know.
Which hospital is close to the Bronx Zoo?
Jacoby. We call it Jacoby.
Right.
Jacoby has access to most of the antivenom that you would need in New York City. And yes, that would be the thing. Antivenom, antibiotics, and admit to the hospital.
Dan
Now-
Golden actually gives a lot of antivenom.
What
Alvin
else?
does. Dan Golden. I was just talking to him not too long ago. He has to give a lot of antivenom for snake and scorpion bites.
Well, he's in Vegas.
Yeah.
Yes. Oh, there's definitely those locations. Now, one of the other things that we do for snake bites to try to minimize its spread, obviously this person doesn't have it on his hand, but clearly you see this kind of swelling is not uncommon. So if they started out with any kind of rings or jewelry, just making sure that at the scene, those are cut off as quickly as possible, because this kind of swelling is definitely pretty expected for a lot of the different snakes. So two, one of the things that we do for transport, one of the things that we talk about, right? We talk about lowering it, talk about immobilizing the hand enough that it's just, because the movement, the more you move the arm, wrist, the fingers, elbows, the more you're, worsening circulation of venom. So, but if you do immobilize it, you have to keep it exposed, be able to mark the chains. You don't want to cover up seeing progression of any kind of cellulitis or redness. But a lot of the things that can happen are only going to be reversed by the antivenom, because antivenom contains all sorts of nasty stuff. So in addition to the antibiotics, you're giving the antivenom, and you are trying to keep them from moving their arm as much as possible. And you're trying to keep it below the heart a little bit so that it doesn't minimizes the circulation systemically, because there are not just local toxins, but systemic ones as well. Anything else?
We do one of these things with Dr. Moore, he mentioned elevating the arm above the level of the heart. Would you ever clench the arm in that position and hold it upwards? Or I guess, like, how would you achieve that? Just have the arm hanging off like an IV pole? I'm just curious.
It depends on whether you think there's systemic or local effects in terms of trying to decrease the circulation to the arm. Keeping at the level of the heart is probably what I would do for most times. What about you, Oz? It's been a while since I've had to deal with this.
Yeah, I'm not sure I have anything to add as far as that goes.
Yeah, no, I think it's, keeping it above the heart is going to decrease the flow to the arm, and it's always a balance between keeping it at the level of the heart is a neutral action. If you keep it less than the level of the heart, you have less systemic. Keep it above the heart, you have less local. That's going to be what you're going to try to use that to sort of play for a given case. Key is immobilization. All right, what do you think this is? This is a, just seeing this, what do we think this is, what do we think is most associated with this particular injury? What injury do you think we see here? How can we describe what we see here?
It's like Popeye.
Right, so Popeye means some muscle is deformed. What do we think the muscle is that's deformed?
The biceps muscle
tear?
rupture.
Right.
or
So this is a
tendon rupture.
biceps rupture, tendon rupture, with increasing that bulge. What do we want to do for that? What do we think? So what do you think applies most in this?
I mean, it probably is mostly in men.
Exactly. Yeah, they try to do stupid things a little bit more than women do. But yeah, in the end, what is the mechanism we think is related to this?
Lifting too heavy weights.
Right. So just trying to pick up something that's much too heavy.
Forceful extension in
Right.
flexion.
Against a contracted muscle, right? So you're contracting it, it's flexed, and then some force forcefully extends it while you're doing your maximum attempt to keep it bent, or you're actually trying to pick up something, which is very similar. You're actively trying to pick up something that's just too heavy for you to possibly pick up, but you try to overexert, and the tendon can rupture. Which is the feeling about this that makes it less likely. It's not really usually flexion against an extended arm. It's usually, the arm is usually flexed to some extent. And that's the only thing here that, and it's not associated with IBDA at all. Okay, so we got that predominantly in men. Just like the prior slide, the snake bites are also predominantly in men. Genetic. This one. What is the most appropriate therapy for this patient?
Did this person punch somebody else in the mouth or?
Very good. And even if they didn't say it, you can presume that they did do that. Yes, this is a closed, clenched fist injury.
The key for this is, oh, wait, never mind. Now I'm confused.
Good. I'm glad you're confused. How many people think that none of these are the right answer?
Me.
Very good. Why? Because every single one of them includes closure.
No, close.
Right? Do not close these wounds. The chance of infection is just off the charts, right? For these kinds of clenched fist injuries, with injection of what was in the teeth and the mouth of wherever they punched into joints, deep space infections. So while you will irrigate it, and while you will give tetanus and antibiotics, it probably needs to be irrigated in the OR, and you can splint and admit just to minimize pain, maximize comfort. That was a trick one. I said, let me make it from an easy one and make it harder for you to think, but no closure, please. Any questions? Good. I won't do that again to you, I promise. All right, next one. This injury requires I'm sorry?
So the pinky finger on the right hand in the picture is rotated.
Exactly.
So that makes me think that this is a proximal phalanx fracture.
Okay.
So I would want to try to reduce it. And I would probably, if I had a choice between giving pain medication and not giving pain medication, I would probably give pain medication.
Right.
So
Good.
I think I don't know. I'm gonna go out on a limb and say D is the right answer. I don't feel like these people necessarily have to be seen within a week, but I don't know for sure.
Okay. What do the other people think? So what are the types of finger fractures, that's when we're thinking about it, that do require surgical intervention? Because without it, there will be real functional deficits if it doesn't heal properly. that's, I guess, the question we're trying to get at. And really, rotational injuries, even to the fourth and fifth finger in particular, really result in significant functional problems with even small degrees of angulation, of rotational displacement. So that's why the follow-up within 7 days ends up being the answer here. Obviously, if things are so deformed and you can't reduce it at all, we think about it. But these kinds of subtle rotational fractures really do have tremendous functional impact. And so that's why follow-up within 7 days is the answer here. And just to remind us, it's interesting how when you do flex your fingers, they are supposed to all point to the scaphoid. And this is clearly an example of one that did not. But I don't think you need this diagram just to realize that. But clearly, that's the reason. All right, next hand. 65-year-old dry cleaner presents to the ED with this condition. 24 hours after feeling a prick in his finger. His past medical history consists of COPD, CHF, diabetes, hypertension, stroke, CABG, and AFib. And this condition would best benefit from analgesia in which form? Well, first of all, what do we think this is? What do you think this is?
Is it flexor tendinosynovitis?
Right, right. One of the Neils says FTS. That's a very interesting, I don't know if I've ever seen it that way. But so what do you want to give? Is this something that if you give a digital block will help for as long as this person's going to have pain? Can you fix this in a few hours?
Sounds like no.
Sounds like no, right. So this is something that is likely going to need tremendous pain, is likely going to need intravenous analgesia. But that's not the important thing is recognizing what it is. And what else? Are you going to get an IV for any other reason besides the intravenous analgesia? What's the treatment for this?
Antibiotics.
And IV antibiotics and admission to ortho for possible surgical debridement, right? Canavel time, right? Just make sure you just, it's so intuitive, but as long as you, when you call ortho and say, I have a patient with Canavel signs, all four of them, that should get their attention. Also, you can send them pictures, but nowadays. But they know this is what they have to deal with. Any questions? Anyone? Now that particular picture, they want to know the person who put it in there. So it was actually a real patient they took care of, and they were cleaning a gas gun, and it went off in their hand. Oof. That is deep space infection. All right, 3-minute break. Then we'll come back and do a lot of short answer ones. Unless you guys don't want to take a break. I'm happy to take a break for 3 minutes. Okay, a minute it is.
You do what you want. It does whatever you want.
All right, we'll take at 5 minutes to, we'll start again. Any questions so far? Anything we've talked about? Anything anything about what we talked about? Want more clarification? I'm happy to, if I don't know it, I'll look it up.
Not directly related to this question. Are there ultrasound findings for flexor tendinosynovitis?
I have never used an ultrasound to do a prognostic kind of staging for it. It's really been the clinical exam. But I don't know if anyone has tried to put an ultrasound on it to find something pathognomonic. I'm sure you would see. I don't know. I don't know whether you would see air any particularly more. I think it's an infection, in the deep spaces.
Yeah, I think you're going to see cobblestoning. Like you're going to see probably infectious, like cellulitis type findings.
Yeah, like
Okay.
a cellulitis, right?
I mean, I think this was an interesting one though, Jordan, because if this was a high pressure injection injury, it's kind of like, right, like you're essentially getting a compartment syndrome,
Right.
right? So in this particular one, you could see error in
Mhm.
addition to all the other things. So this is a little different, you know, than your classic. You got an infection and then the infection ran, and then you get the like flexor tenosynovitis from an infection.
Right. I can't imagine this patient not going to the OR as quickly.
Well,
as
I think the finger is going to be gone, Jordan.
Yeah. Yeah.
And you can see how it's distal ischemic completely.
Yep.
But that's the thing, like flexor tenosynovitis, you know, the finger, you can save the finger unless it, you know, just was left for too long.
Okay. There's only one slide. I think there's only one slide that I pushed back here, just because it was sort of kind of, I pushed others up there. So a 65-year-old female presents to the ED for agitation. After she is given a medication for the agitation, the following is what happened. You see that picture. What is the appropriate treatment for this condition? What do we think is going on, and what do we want to give?
Give that Benny.
This tonic reaction.
Okay. And you're giving what to fix it?
See.
Okay. Or 3. Okay. Yeah, diphenhydramine, any antihistamine for this, you know, this particular type of
What other medicine?
what?
And I was just saying, there's another medicine they could consider, like, if the as another option.
Benztropine.
Yep, cogentin, good. Benztropine. Good.
So antihistamine, exactly. And and we also call it when it's the neck particulars. What do we call it when it's the neck in a dystonic reaction?
Torticollis.
Right. Okay. There are other things that you can also see that are, thankfully, I haven't seen myself. Eyes, there's an ocular gyrus crisis that can sometimes also occur, treated similarly. But any kind of muscles, you know, movement that's not controllable by the patient. All right. Patient with this abnormally appearing venous blood sample. So the top is what is the venous, normal venous sample. The top one is a normal venous sample. What do we think is going on if the bottom is what you're actually drawing from the patient venous sample? And what is you think is going on, and what do you want to treat it with?
So it's very red.
Right. Very good. So very
So,
red.
Is this
That makes
carbon
me-
monoxide poisoning? Something like
Okay.
that?
Yeah, carbon monoxide poisoning can definitely do this. Exactly. Unless
Wow,
it's
Neil. Wow.
Thank you, Neil. So would you do like hyperbaric oxygen?
for the choices that are here, it's the only thing, right? So high flow oxygen improves it somewhat, but hyperbaric oxygen will even faster improve it. The question, this looks like it's someone with a lot of changes in the color of their blood. It'd be interesting to see what their percent was. They talk about percent of carbon monoxide. What do people think is the, what are some of the things that we talk about in terms of carbon monoxide and whether we refer for hyperbaric?
Number higher than 25. Or if they have signs of end organ dysfunction.
Right. What are kinds of end organ dysfunction?
You can have, if they have lactate, if they have troponin, those types of things. Altered mental status.
Altered mental status, right? Mm-hmm.
If they've got a big fracker. Yeah, that's I have altered mental status because I can't speak. Maybe I should get a bunch of oxygen.
Mm-hmm. And what is the cutoff that we say for hyperbaric? What are some of the things that What are some of the, what could be a condition that makes you have a less cutoff?
Sorry, I don't.
Neil,
What would
Neil
be
says, Neil says
right,
pregnancy.
exactly. A pregnant patient, because of the increased affinity for fetal circulation, the fetal blood for the carbon monoxide, it would be your cutoff is lower, like 15, I think it is. I have to look it up just to be sure. Do you remember what the cutoff is? It's been a while since I've had to, but whatever the number is, you look it up. Unfortunately, giving oxygen, if you have no symptoms, no mental status changes, no cardiac arrhythmias, right? This is the other thing that high carbon monoxide levels can cause is cardiac arrhythmias. Obviously, if you have any of those kinds of significant findings, you're going to want to, no one's going to fight you on giving hyperbaric treatment. Cornell has a single chamber hyperbaric chamber. Jacobi has a walk-in multi-patient hyperbaric chamber where there's actually a physician or a provider in the chamber the whole dive and back up, which for more unstable patients potentially is a little bit safer. And that's what you would do. Any other questions? Let me just see here.
Is it true that the only thing it's been proven to do is improve cognitive function at 6 months? It doesn't improve survival or anything. Is that right?
I'm not even sure about the cognitive function one, but it definitely reduces your carbon monoxide faster. And that's proven, but you're right. What's the actual clinical outcome that's improved is tough. So if you don't have access to carbon, if you don't have access to a chamber, you're just giving, you're giving high flow oxygen as much as possible. Yeah. All right. Anything else? Okay. So that's that. And we're giving hyperbaric oxygen. Okay. Now here, you've got an arterial sample. Okay. The right is the normal arterial sample, red. This is what you draw, on the left is what you've drawn from the patient. And they were recently started on antibiotic. What is the best treated with? What do we think is going on? And what was the treatment?
I'm going to say that this is methemoglobinemia.
Let's stop it.
Sorry, can you please speak more clearly into the microphone, Neil? So I would get, if this is methemoglobinemia, I actually saw this once. We were all very confused, and then Sam Centuria came on to shift, and he looked at the patient, and then he got the answer in 5 seconds, because the patient was started on dapsone. But if this is methemoglobinemia, you would treat with methylene blue.
Correct. Exactly. What is it that you are seeing? You're seeing a blue patient, and you give them oxygen, and their blueness does not get better. In terms of yes?
We just had, Jordan, we just had a case about a month and a half ago, a notification for hypoxia, and the guy looked blue. And I think that what made me think it was methemoglobinemia was he was blue, but was interactive with his SAT. His was 88. They say it would be 85, and it wouldn't go up with oxygen.
Right.
And so, yeah, I mean, I had seen a few cases at Jacobi when I was a resident, and for some reason it popped into my head that it was methemoglobinemia.
And you do like so you have this low pulse ox reading, but then when you draw the ADG and you're looking at the O2, it's like normal. And that's not true. I mean, the normal is also a error on the wrong side that way based on how the ABG is calculating the SaO2. But that gap between falsely normal SaO2 from the AVG and the depressed SpO2 that you're getting on that gap that's like, wow, these don't match at all, is also in addition something you'll find. But I think the color
and the blood is truly chocolate brown. I mean, it's very brown. In fact, the resident who was drawing the blood was like, whoa, this blood is really dark, before I had said anything. So it like sort of was the clincher.
Right.
And then the lab canceled the ABG because they said, oh,
that can't be true,
brown.
right?
They said
Yeah,
it looked
yeah, we never
brown,
got the
we
methemoglobin
knew it
level.
wasn't the
I heard Tyler's conversation with the lab tech after shift. I've never been more entertained.
Unbelievable. Unbelievable. Now, surprisingly, what is the most common drug associated with this? Even though we think about things like dapsone, what's the most common drug associated?
Do you want the common name or do you want the chemical name?
I'm happy with the common name.
Do you mean the most common drug given by doctors or
Correct.
taken by patients?
No, by doctors, by doctors who are not doing bad.
I would guess I was at Jacobi. My case was a lidocaine case.
Right. So benzocaine. Benzocaine is the most common. Lidocaine follows it. Dapsone. What are you thinking of?
Poppers.
Poppers, right? Nitrates. So nitrates in general. Nitrates can also be in drinking well water for babies, so yeah, that can sometimes sneak into people's diet. All right, so we got methylene blue. What is so we talked about hyperbaric oxygen being for
Carboxy,
right, and then we talked about what is sodium bicarb a reversal for? You don't see a lot of it nowadays.
Tricyclics.
Tricyclic, right? Tricyclics. Then we talked about the methylene blue, cyanide antidotes for cyanide, calcium gluconate.
Although we don't use the cyanide kit anymore, really, right? The Lilly kit.
Well,
because hydroxycobalamin, cobalamin became FDA approved. It for a long time was just approved in Europe, and we were stuck with the Lilly kit, which is interesting because the way you treat the cyanide overdoses by creating a methemoglobinemia. So you trade one problem for another one, but now with hydroxycobalamin, you basically turn their cyanide poisoning into a B12 injection.
Which is much better.
People pay for that.
All right, so just give the B12. All right, next.
Oh, and Jordan, to answer your question, the calcium gluconate, right? Like, obviously hyper K, but hydrofluoric acid, right? That's the
right, hydrofluoric acid, right? Yeah. Okay. All right, so this is just another example of the chocolate brown compared to the red from methemoglobinemia. Now, what do you think is the most appropriate initial intervention for this patient? Severe pain. This patient had if I told you they were a jewelry cleaner or just worked with chemicals, but didn't have anything, went home, felt fine, and then all of a sudden this pain started becoming more and more intense. What do we think this is? What's the initial intervention for this? Initial. And what do we think it is?
Is the answer E?
Decontamination.
Right, Neil is right. Decontamination. Decontamination is your best initial intervention for any possible chemical exposure causing any toxicological symptoms, but definitely for this in particular. But just making sure there's nothing on them, any clothes or anything that could continue to cause deep injury to tissue. But you're absolutely right. So, and the reason why calcium ends up being a little less appropriate is it a calcium infusion that's your first step? what's the way we tend to start giving calcium to these hydrofluoric acid patients?
I guess we put it, or we put it on their arm. We put it on the top. I think it's topical, right? You put it on the affected area.
Right. You make a slurry with the calcium gluconate, and you use that slurry to in a glove sometimes, or just to sort of have it sit in it, and that draws off the hydrofluoric acid from the deep tissue as best it can. Sometimes you do arterial. It would be an arterial infusion, but that is, pretty big deal. That would be very, someone is. I have not had to do that particular maneuver, but it's out there as a potential other thing. But you can imagine intraarterial calcium gluconate is not a small thing to go down.
So how would you decon this patient, I guess?
So just a normal decon, soak, water, get everything off, and then start your calcium, topical calcium gluconate slurry. But yeah, you would decontaminate means just make sure the clothes are off, make sure that there's nothing that could have drops of it on there, because it's such a delayed thing that if it's on clothes and kind of makes its way to the skin, it'll be a slow burn. It's a delayed onset symptom. So I don't know how long the person took to get here, but it's definitely something that you want to be extra careful of, because it's not going to be as obvious. It's not like right away it starts burning the moment it touches their skin.
And how long would you keep the topical
symptoms? It's symptom driven. You're trying to get the symptoms to start feeling better.
Yeah, and when we make, just so you all know, when you're making that slurry, we use Surgilube, and then they take the calcium gluconate powder, and then they start mixing that together, and we put that on. Jordan, that looks concerning. Like, that one looks bad. Like, that's been on there for a while.
Yeah.
I did it. I've done it twice with the intraarterial calcium, and it was something horrible like this, where it was like.
Is this typically like someone who works in industrial settings? Like,
yes.
Is there anywhere else you can get hydrofluoric acid?
The only other thing is the only time, I mean, the only death that's reported that was horrible was industrial hydrofluoric acid that got on a sanitation person, where the barrel of it that was being trying to throw it out was splashed on them, and they had like instant death. Because it was a big barrel, giant storage barrel worth of hydrofluoric acid. But yeah, so sanitation people can sometimes be exposed to people who dispose of it. But usually it's industrial cleaner. It's industrial cleaner, a lot of times in jewelry. But any kind of mechanical cleaning could potentially have it. Anything else? That's it? Okay. All right, some quick ones. What do we think this kind of skin lesion is?
This basal cell?
Most common, yes, absolutely. It's the most common type of skin lesion. It has, the question is the history and is it changing, but the irregular borders, the sort of rolled, pearly rolled border here, all of these things are what makes you worry about basal cell carcinoma. And it is something that exposure to the sun makes you more at risk for. Now, if it's on the lip, what do we worry about? These tend to grow much faster. And when they're on the lips, other sun exposed areas, what do we worry about?
Squamous.
Squamous.
It just doesn't, I don't know. It doesn't look like the weird mole that.
Yeah, and this is on the lip. It's mucosal. Yeah, and it looks more angry looking. So if it's not an infectious and if it's non-painful, which it often isn't, and it's been growing over a period of time, like over a week, 2 weeks, that's when you start to really worry about this. And this would be what kind of skin lesion?
Looks like melanoma.
Right. This is more of the melanoma look, and change over time is the most important. People can have moles like this when they're born. The question is, it's a little different in the color in one area versus another. And if this just appeared after 30 and has been growing in any way, that would be the next thing we need to send to dermatology for. Okay. Treatment of the following includes what do we see on this X-ray? That's abnormal. It's not the bones.
Is that air?
Yeah. Where top, bottom, back, front.
Like the dorsal aspect of the foot? I'm just seeing these pockets of air.
Right, all along just underneath the skin there. So, what do we think this is?
It's like neck fash.
Neck flash.
Right, so diabetic foot ulcer with gas gangrene type of a finding. Treatment for this?
Debridement
You
and
give IV
antibiotics.
and IV antibiotics. Uh-oh, if you have to give debridement and IV antibiotics, what does that mean? The choice has to also include?
Do we have to give oxygen?
Yeah, hyperbaric oxygen has a role in improving morbidity with these patients for gangrene, this type of gas gangrene. So, you know, Clostridium infections are definitely anaerobic, and exposing them to oxygen greatly accelerates their ability to be controlled. So it actually is one of the few sort of best studied things for hyperbaric oxygen, more than even the carbon monoxide. All right, A, B, and C. Rapid, and then we're done. We have 15 minutes. Let's see what we can do. Patient with painful swollen left leg looking like this over days.
Cerula dolens.
Right. This is phlegmasia
Phlegmasia
dolens. That's the full name. What is the now this is the caused by such venous congestion at this backflow, and you're seeing these circulatory changes from venous insufficiency, inability to leave. What is, and these are very large clots. I would think the data is saying that these should probably be thrombectomies, but it's, you know, you got to convince your surgeons to do that. And what if it gets so bad that you start seeing arterial insufficiency? The venous insufficiency based on a venous clot is so great that there's arterial insufficiency because of weak arterial flow. It can't get arterial flow. What do we call that?
Compartment syndrome.
Maybe. Question. No, it's
Is it another one
another
of those
phlegmasia. It's
Latin's one?
phlegmasia. It's
Yeah.
phlegmasia alba dolens.
Alba.
Alba.
I've
Okay.
seen this. Yeah, I've seen this a few times, and two of the times it was just so bad, and we actually ended up getting a CT venography of the abdomen and legs, and also PE study for some of them if they were like tachycardic. But one person had clotted off everything below their IVC filter, was just straight clot, and their like toes were dying. It was very bad.
Right.
So you can get CTs can be helpful on these people while surgery is, or vascular, you know, whoever you call is helping get all this coordinated.
Right. Now that teaches a lesson about umbrellas. Those IVC filters only work for a short period of time. They protect you for, you know, weeks to months, and at that point your protection is gone, and they can clot off just like anything else. If anything, they're almost guaranteed to clot off at a certain point. So patients with IVC filters are definitely at risk for very large clot formation. Okay, what do you think about the vessels on this particular picture? We're not seeing the face, which also could be a little swollen.
Is this SVC syndrome?
Exactly, SVC syndrome. You don't see anything in the abdomen, nothing that makes you think about this being hepatic. It's all in the upper chest. You're looking in the pupil, you're looking at the cornea. What do you see here?
It's a cherry red.
Cherry red. What do we say that means? Cherry red spot is
CRAO, central retinal artery occlusion.
Right, and the reason it looks that way is because it's the one area, the fovea is the one area of the retina that gets a different blood supply. Because it has a different blood supply to that one area, when everything else goes pale, you see it looks like a red spot. Okay, and that's the only thing. You could also see things like the arteries being less prominent, as well as the overall paleness, which is what you're seeing here, compared to this.
Blood and thunder.
What do we think this is? Sudden, painless vision loss, just like the other one. Blood and thunder, that defines what?
You got it. Yeah.
Right, venous. This is the
ERVO.
chronic. Right, this is the retinal venous occlusion. Okay.
Wait, how do you manage the arterial one?
All right, so it's very good. So this is very interesting. If the person comes in within 4.5 hours of onset of loss of vision, what can you do?
The TPA or like neuro.
Exactly. This is a stroke. This is something you call. So if someone comes in the same time frame as any stroke, acute, because really it's just thrombolysis. It's not really a thrombectomy case, but a thrombolysis. This could be a thrombolysis case like any other acute stroke. So calling neuro for this is actually not unreasonable if it's in that time frame. And then you have to just convince them that, and hopefully they're mobilizing people just as fast as anyone else with a. Anything else you wanted to add? Bennett?
A split pace.
No, just I'm a masseuse, you know. So,
Oh, the rubbing the eye, the massage of the eyeball. Yeah, I did that for a patient. I don't know how many times. I
it's
one case recently, and I just
it's like the feudal things that we do, you know. Sometimes they tell us. You know.
maybe you just
So
lost.
this
the
is, I'm forgetting, this is generally painful, or it's also
No,
painless?
painless.
Less, yeah.
They're both,
Right.
so they're both
You're painless, or you're going to be your like CRAO, CRVO. It's going to be your vitreous hemorrhage. You know, like those are things that to think about.
So like optic neuritis can be painful.
So that'll be painful usually.
Okay.
Like optic neuritis will be painful. Acute angle closure glaucoma will be painful.
Yeah.
Right, like a retinal detachment likely will have like somebody got trauma and then just happened that happened, unless it's like a spontaneous one that happened in somebody with Marfan's or airless
More of a
down.
visual field cut. More likely a visual field cut rather than a full loss of vision.
Correct. Yeah.
And with the arterial occlusion, if it improves and the vision improves, that's a TA workup then. But if the vision is still gone, then TPA.
Yeah, what's interesting about this is the one where normally we think of arterial occlusions as worse than venous occlusions, but for the eyeball, the venous occlusion, you know, right, functionally is like a DVT of the eye. That's worse than this one.
You look at the hair and you see this in the hair, and you stop. What do we think this is? So this is. What do you think these little things are on the hair?
Lice.
Yep.
You
Yeah.
have to give the patient a big hug.
A big
Because they
hug,
probably don't
yeah,
feel
big
good.
hug in a full dress of everything, hair, net, everything. All right, what do we think this pattern is?
Brugada.
Right. So remember that Brugada can be, if you just see this and there's just an incidental finding, what are the things that you need to see in addition to this that makes you have to get cardiology to intervene? Like, what are the things that in the history or the presentation, or is it anything? You see this and you're immediately getting cardiology involved as a stat consult and admission?
Your family history, syncope.
Right. What else? So family history of sudden death before 45, and this makes them at risk for that. So who needs an ICD is the question, and that's one. What else? Obviously, if they've had VFib or VTAC, I mean, that's a no-brainer. They would need it for a variety of reasons. Family history, we talked about. Even if there's documented family history of this type of EKG, that actually seems to increase the risk as well. And syncope, if someone presents with syncope and you're doing this EKG, that's when you're saying, oh, this person needs an ICD. And so that's when you would that would be and those are the main things. Obviously, things that make this worse: alcohol, fevers. So we talk about, making sure that if they have even a viral infection, that they're treated pretty aggressively, because that can make things worse. Their brugada come out more. That's it. All right, so that's brugada. This is, what do we think this pattern is?
Right heart strain.
Okay, so there's a little bit of an axis thing. Why do you say there's an axis?
They have an S in 1. They have a Q wave in 3 and a flip T wave in 3.
Okay.
And they're tachycardic.
Okay. All right. I could buy that. I think there is another thing that's here. If you look at AVR, the idea that you have an R wave that's pretty pronounced is the only thing that they're looking at. It's not something we tend to look at. We really do have a lot of scotoma in regard to AVR. We don't look at it very often. And you would have to have a clinical picture. And actually, it's very important to keep in mind that R waves are not predictive of toxicity. They're just predictive somewhat of more common in TCA using patients than not. It is not to see this R wave and AVR is, again, not prognostic. What is prognostic in TCA overdoses is what on the EKG makes you really start to sweat?
QRS.
Widen QRS. All right, so this in a TCA overdose is terrifying, because the toxicity in the heart usually precedes the toxicity of the brain. And when the toxicity of the brain reaches a threshold and they start seizing, these are seizures that are refractory to every treatment known, and they tend to they die from if they go into seizure. So your goal when you see this is not just the heart going into any kind of arrhythmia, but just to prevent the brain toxicity. So what's the treatment for this? TC, we talked about earlier, TC overdose, the antidote is?
Sodium bicarb.
Sodium bicarb. Probably more the sodium than the bicarb part, but so giving high dose sodium of some sort, but the safest way to give sodium is sodium bicarb. And what you should see on the EKG monitor is as you're pushing the sodium bicarb, you actually should notice the QRS narrowing. It is that rapid a response. Okay. This.
Yeah, just remember that TCA is that the bad part there is they're sodium channel blockers, right? And so you're giving sodium, so that's why it's effective.
Exactly. All right, so let's say the top EKG is when they first come to the emergency department, and while they're feeling a little bit worse, you see the second EKG on the same patient, and it can be anything from feeling a little chest heaviness, maybe a little feeling of a little difficulty catching their breath. What is it you think that's going on in that second EKG that's more prominent than even the first?
Electrical alternans.
There you go. Sign of?
Tamponade.
Effusion, right? Large pericardial effusion, which can turn into tamponade if you have other signs, but the main thing is it's a large pericardial effusion, and the heart sitting in that sac is kind of moving as it beats and changing the axis just from that sort of.
I had this the other day. It was crazy.
Yeah.
What'd you do, Neil?
I saved their life. That's what I
Oh,
did.
excellent. Was
That's what we
is
do.
that-
It
Is
was a
that
typical Columbia day where it was like one of my worst shifts ever, where I got like 17 notes and all of them came at the same time. And she was like a STEMI activation. She syncopized at home. And then I was like, that sounds weird. And Cards was like, nah, it's not STEMI. I'm like, okay. And we like rushed her to scan because we're like, oh, could this be a PE? And then I looked at the dry scan myself and I was like, oh shit, there's like a lot of fluid around her heart. And then I sonored her and Cards got involved into the cath lab. But yeah, there was electric alternating in EKG.
Yeah. On the EKG, and then Isono. This, so it's because it's 10:30. I want to try to finish. This would be an example of from vaginal fluid
Burning.
burning. Okay, that's a sign of. Is this something you'd refer to ACS?
Mongolian spots.
Would this be something you refer to ACS?
No. Oh, this one, yes.
You sure?
No.
Cultural practice.
Yeah. That.
What is it?
It's like it's scraping.
This one is more an example. I mean, I guess this is an example more of cupping.
Cupping, right?
Cupping, where you light some source of small flame under a cup, and when as it burns, it creates a vacuum.
The cupping makes circles. This
Yeah.
is like it's like a form. It's like Chinese medicine. You like
Oh,
scrape.
you're right. Dermabrasion. You're right. This is dermabrasion. You're right. The next one is this says coining, right? Coining, abrasion. You're absolutely right. Coining.
Wait, what is this? Like, this is just like a cultural thing?
Yeah.
Interesting.
Get rid of negative energy. Coining.
I
You're
should try-
absolutely right. Sorry.
I need to try it. Matt, can you do this on me?
All right, last ones, and then we're done. This is a, what do we think this is? Do we see any light spots?
on the patient's on the left side of this picture, the patient's right?
Correct. What do you see?
Probably a maybe traumatic subarach in a
Right. And what else are we seeing with the traumatic side? Do we see, what other things we're not seeing that we would like to see in
Is this
this?
shaken baby?
we don't see any like gyri.
Right, the diffuse axonal injury, right, loss of the gray white border. This. Little different from the other one,
Are these retinal hemorrhages?
more like retinal hemorrhages, right?
Some shaken baby syndrome?
Could be. What do you think this testicle is doing? Pain, if there's severe pain. Premasteric reflex is absent. Portion, okay. Often half the time it happens when people are asleep. This, priapism, I'm not going to worry about that. This, if I told you this was like a sheep farmer or other kind of livestock worker.
Is that a bot fly?
A what?
Never mind. I'm definitely wrong.
Yeah, I agree with JP phone.
What is it?
Well, if you think about sheep, what is the association with sheep?
Right. No, someone said it in the comments.
Oh.
And,
It's
Anthrax,
yeah.
cutaneous anthrax.
Is this contagious if you touch it?
I don't know. Neil's probably touched one of these. Neil, did you get it? Did you get contagious? Did you get infected?
So the
Neil
good news
probably
is,
licked it.
yeah, it's you don't breathe, you won't get it by breathing it, but you will get it by touching it. Cutaneous anthrax. This is something you thankfully don't see as much anymore in someone with severe immunosuppression. What do you think this is? We really don't see a lot of this. This would be Kaposi sarcoma. Yes. We really don't see a lot. Thankfully, we don't see a lot of this, but you have to be really low CD4 count, like, definitely less than 200, but, it really is. This. Something else you could see in someone with very low CD4 counts.
DMV retinitis?
Right. You'd get some history to diagnosis.
emergency medicine board review. I have to do mine
There you
in
go.
December where I have to talk about orthopedic stuff.
And this? Also someone with low CD4 count? You see this chest
Yeah,
X-ray?
like couple of different people give lectures. So
What do you think this is? From a chest X-ray, low CD4 count, hypoxia, high
Is
LDL,
that mediastinitis, the bat wing sign?
bat wing sign? Yeah.
Well, it's Batwing, but it changed its name.
EJP.
All right. It's PJP, right? This is from before. This is just simple. What do you think? What all the things you see on this chest X-ray? Obviously, we see a fluid level. Do we see anything else?
Mediastinal shift.
What else?
A big pneumo.
Big pneumo. Unfortunately, thankfully, you don't see very often. It's more common in other countries.
Is that tetanus?
This is tetanus, yeah.
Oh man, that's awful.
I know. Paraphysmosis and physmosis, just know, one clearly for physmosis, you don't have to worry about anything acute, but it can be dilated, topical steroids, dilation. But for the other one, paraphysmosis, you have to call, that's something that can cause necrosis without being fixed. So this is something that you try to reduce in the emergency department, and they don't leave until it's reduced. Okay, this is as opposed to this, which is just simply more just some infection of the gland. We call this
balanitis.
Right. This is something interesting. The ear. What is this? This is someone with it looks red. It's a little painful. They didn't. In this case, there's nothing here, but sometimes it happens. Often happens after some sort of either earring placement.
Perichondritis.
Right. Versus something like this, which was, after some trauma, or what we call this?
Auricular hematoma.
Right. And this is something that should be drained sometimes initially with just a needle. And if it doesn't come back, that could be enough. But if it does come back, it may have to be fully IND'd. These are the things that sometimes need pressure dressings. You try to, if it does keep accumulating, again, very similar to the septal hematomas, the skin overlying it causes with this hematoma, the cartilage loses circulation, which is why a lot of these wrestlers, Greco-Roman wrestlers, they develop, when they have this, it's not treated, the cartilage starts to get deformed over time. But we used to, with every suturing of everything on the ear, we used to always put pressure dressing, and we're finding that it doesn't help. So it's really for something that is clearly developing a hematoma, rather than trying to prevent a hematoma in like a suturing of the ear or even an avulsion. We only do it if you see something like this that keeps coming back. Name the tooth number. How many are on the top? How many are in the bottom?
Is it 19?
Well, how many are in the top?
Like
how many teeth are at the top and bottom?
Neil, how many teeth do you have, Neil?
I think it's 18. 18, right?
I think it's 1 to 16.
Neil has 3.
Everybody has 32 teeth. I have a lot less because I'm older, but in general, we're born and we develop 16 teeth on the top, 16 teeth on the bottom. So if that's the case, what do you think?
31.
What?
31.
No. You start. It's weird. You start upper right, and you come.
Neil, you were right. You were pretty close. I think you. The molars.
19.
The molars
okay,
are.
okay.
Yeah. So it's not
All right.
19. It's like 18.
18,
okay.
right. So you start with the top right, and then you just go around to 16, and then you continue on to 17 right below it. No, this was something you just have to remember because it makes no real sense. This is what they came up with. All right, and especially because people have all these teeth removed, you got to know what teeth. You got to make sure you count and make sure that they're not missing teeth to know how to then give the right number. So this injection is for what? This location?
Is that inferior alveolar nerve?
Very good. And this is sort of a better picture to sort of look. You could also get the buccal nerve is also in this sort of area, and that's going to give you that. And then these most common injury for this fracture. Humeral neck fractures, humeral shaft fractures. Huh? What's the one that wraps around there?
Axillary nerve.
The radial.
Yes, the radial nerve. Yeah, so this is more like a mid shaft, right?
Mid shaft, yeah.
Yeah, so
dislocations can be associated with.
It's the dislocation, right? That you were about the accident. Yeah.
Which type of fracture is this? What number out of 1 through 3? Since we.
That's
This is the most common one.
It's I'm gonna say 2.
2, right? 2 is actually is 2 the worst or the best?
2 is the middle-ish.
It actually is the most unstable. It's the unstable one, actually.
Oh, really?
The most unstable, yeah.
Yeah, surprisingly, even more than the base, which a fracture that goes through the base. Okay, next.
Ooh,
trauma 101.
Open
Sesame.
fracture.
Yeah.
All right. Treated with a binder, and if needed, if there is bleeding, either some sort of interventional radiology. This is I'll skip this. Reducing a dislocated jaw, it just shows really an example. They don't really do much. What about here? If you saw a lateral x-ray and it looked like this, is this normal or abnormal? And what's your guidance?
I think it's against HIPAA to show pictures of Neil on this slideshow.
Any Neil.
Yeah, I think so. This is abnormal. There's lots of vertebral soft tissue swelling.
What's the mnemonic that sort of gives you guidance in terms of what you should be expecting?
It's 6 millimeters at C2 and 22 millimeters at C6.
Or 2 centimeters at C6, right?
Or 2 centimeters, yeah.
I don't know if I can tell the difference between 20 and 22 millimeters.
Yeah, close enough.
All right.
Yeah.
But this here, if it wasn't trauma, where you start worrying about prevertebral swelling and something of trauma indicating fracture, here with not trauma, it could be a retropharyngeal abscess. This is a normal. This is what normal the prevertebral space should look like. Much different.
Yeah, and that kid too, like those kid injuries, it's like a kid who's running with like a lollipop in their mouth or something, and then it pokes back through there, and that's how they get the RPA.
And last but not least, 5-year-old boy with unstable vitals and this rhythm. Treatment and dosage.
One joule per kg, I think.
But they're awake. So you can probably start with 0.5 joules per kg. Cardiovert. You're cardioverting, not defibrillating. Obviously, it's a narrow complex. They're awake. They're just unstable vitals. So 0.5 joules per kilogram. That's it. That's the last thing. Thank you guys for hanging on for the last bit. Everyone who did. Any questions? I'm here for as long as you need if you have any questions, but that's the end of the slides.
So if they're awake, you do 0.5, but if they were completely altered, then you do 1.
If you're starting to worry about if they're so unstable that they don't have a pulse, obviously, but 0.5 will usually get them out of an SVT, which is what that was.